Hello everyone. Today we are going to talk about 20 PYQs from the topic of rheumatology from the subject of pediatrics. So your first question is Gottron's papules are characteristic of, and your options are SLE, reactive arthritis, juvenile dermatomyositis and Steven-Johnson syndrome. So here what you are seeing here in the picture, here you will see these plaques over the proximal and distal interphalangeal joints. You may rarely also see them on elbows and knees. And Gottron's papules, this typical picture, Gottron's papules are characteristic of juvenile dermatomyositis. Gottron's papules, juvenile dermatomyositis. Which among the following are true about ANA, anti-nuclear antibody? Option A is positive in SLE, rheumatoid arthritis, associated with increased risk of uveitis. Some children with positive ANA have no underlying rheumatic disease, and all of the above. So what is true about ANA? ANA is positive in SLE and rheumatoid arthritis. Yes, this is true. It is associated with increased risk of uveitis. This is also true. Positive ANA is associated with increased risk of uveitis. Some children with positive ANA have no underlying rheumatic disease. This is also true. Nearly 30% of children who have a positive ANA on blood, they do not have any underlying rheumatic disease. So the answer to this question is all of the above are true. Which of the following is not a DMARD, that is disease modifying anti-rheumatic drug? So leflunomide, hydroxychloroquine, naproxen and methotrexate. Here the answer is very clear. Naproxen is what? It is an NSAID. It is a non-steroidal anti-inflammatory drug. The other three, leflunomide, hydroxychloroquine and methotrexate, are classified into DMARDs. Anakinra is what? It is, your options are IL-6 antagonist, IL-1 antagonist, TNF alpha antagonist and anti-CD20 antibody. Anti-CD20 antibody. So these are your options. Anakinra. What is the right answer? It is IL-1 antagonist. Okay, remember A is the first letter of the alphabet. Anakinra, IL-1 antagonist is the answer. Dactylitis and onycholysis are clinical features of. So dactylitis and onycholysis, your options are reactive arthritis, psoriatic arthritis, juvenile idiopathic arthritis and enthesitis related arthritis. What is your answer here? So dactylitis, onycholysis, these two are features of psoriatic arthritis. Okay, pitting of nails, nail pitting, right? Nail pitting and dactylitis. These are features of psoriatic arthritis. Secondary HLH, hemophagocytic lymphohistiocytosis, is characterized by all except. So your options are hepatosplenomegaly, elevated ferritin, leukopenia and elevated ESR. So in secondary HLH or MAS, as it is also called, macrophage activation syndrome, you're going to see hepatosplenomegaly, elevated ferritin, yes, leukopenia, yes, but not elevated ESR. You are going to see in macrophage activation syndrome or in secondary HLH, you are going to see drop in ESR because of the hypofibrinogenemia, right? Because of the hypofibrinogenemia. Because of this, you will see a drop in ESR, and that is how you distinguish between MAS, that is secondary HLH, and active disease flare. So elevated ESR is not a feature of MAS, rather drop in ESR is what is seen in macrophage activation syndrome. Of course, you have to also look at other features for a disease flare, but in the context of this question, elevated ESR is not a typical feature of MAS, it is drop in ESR. All of the following HLA types occur in increased frequency with SLE except. So your options are HLA B8, DR2, DR3 and B27. Now remember that SLE is associated with, it has three letters, right? SLE. So remember that the three most common HLA types associated with SLE are HLA B8, DR2 and DR3. HLA B27 is not associated with SLE. Okay, so how do you remember these three? So you remember that SLE has three letters. So there are three HLA types. Remember that there are three doctors, right? DR3. Two of the doctors went on a birthday date, and birthday date rhymes with 8, so it is B8. So remember that there are three doctors, three DR3, and two of the doctors DR2 went on a birthday date, so, or a blind date, whatever. So B8 is the last one. So these three are the ones you will see in SLE. HLA B27 is not a feature. Which of the following is not seen in SLE? Hypocomplementemia, negative DCT, anti-dsDNA and anti-Smith antibodies, and alopecia. So we all know that alopecia is seen in SLE. Anti-dsDNA and anti-Smith antibodies, this is also seen in SLE. Hypocomplementemia, yes, it is seen. You see decreased levels of C3 and C4, right? Negative DCT, no, you have a positive DCT in SLE. Okay, so negative DCT is the answer for this question. That's what you don't see in SLE. Antihistone antibodies are seen in, the answer here is antihistone antibodies are seen in drug induced SLE. So remember that antihistamines, right? Antihistamines are drugs, right? A class of drugs. So antihistone, you remember that as, those are seen in drug induced SLE. Heliotrope rash is seen in, what you are seeing here in this picture, this child has heliotrope rash on the eyelids. Okay, this is this pinkish rash on the eyelids with periorbital swelling, and this is a very typical sign or clinical feature of juvenile dermatomyositis. Heliotrope rash is a feature of juvenile dermatomyositis. Behçet syndrome, all are true except uveitis, oral ulcers, venous thrombosis, and all of the above. So Behçet syndrome, you see uveitis, you see oral ulcers, you see venous thrombosis as well as arterial thrombosis. So all are true in this case, right? All are true in this case. The fourth option, they have given it as all of the above, but you could put any other option here because all the others are true. The last option is not true. The classic clinical criteria for Kawasaki disease include all of the following except fever, strawberry tongue, non-exudative conjunctivitis, and thrombocytopenia. Right? Now fever should be there for 5 days as per the criteria. Strawberry tongue, yes. Non-exudative conjunctivitis, yes. Thrombocytopenia, no. You see increased platelet count, you see thrombocytosis, and that you see in the subacute phase, usually in the second week. So thrombocytopenia is not the criteria for Kawasaki disease. Granulomatous inflammation of large vessels is typical of Churg-Strauss syndrome, Takayasu arthritis, HSP or IgA vasculitis, and polyarthritis nodosa. So remember, the question here is saying granulomatous inflammation and large vessels. So large vessels, instinctively it should ring a bell that we should consider Takayasu arthritis because Churg-Strauss is small vessels, HSP also, and polyarthritis nodosa is small and medium blood vessels, right? So here large vessel involvement and granulomatous inflammation, the answer is Takayasu arthritis. Okay, Churg-Strauss is small vessels, polyarthritis nodosa is medium and small vessels, and again HSP is small vessel vasculitis. A 15-year-old boy came with history of night pain in the knees. What working diagnosis will you consider? So remember, now here you read it properly. 15-year-old and the pain is in the knees. Okay. So night pain, yes, you can consider growth pains, but the age and the fact that it is affecting the knees, that's not fitting into growth pains. Septic arthritis, now this is bilateral, symmetrical. Septic arthritis, just a typical history of night pain, it's very unlikely without any other clue in the question. Fracture, again, no. Juvenile rheumatoid arthritis, this can present in with pain in both the knees. So we have to consider this as the diagnosis. An 11-year-old girl came with malar rash, seizures, arthritis, and deranged renal function. ANA is positive. What is the likely working diagnosis? Now, ANA is positive, and this girl has malar rash, seizures, arthritis, and deranged renal function. All this, we all know, this all fits into SLE, right? The malar rash, seizures, and poly or multi-system involvement fits into SLE. Seizures cannot be explained solely with the dermatomyositis, which will usually present with some fever and muscle weakness, muscle fatigue. So this option is out. Rheumatoid arthritis, again, multi joint involvement, and malar rash and seizures is not fitting into it. Same with SOJIA, there will be fever and polyarthritis, so which are not the typical features given in the question. So these are not the options, and all the clinical features are in favor of SLE. So your answer to this question is SLE. A patient with SLE develops fever, arthritis, serositis, low C3 and C4 on lab tests. What is the likely pathogenesis? Right? So a patient with SLE has got all this. Fever is there is serositis and drop in complement levels. Likely going on thing, the likely pathogenesis right now is she is in active disease. Your options are in remission, active disease, inactive disease, drug induced lupus. So this patient is certainly not in remission or inactive disease or drug induced lupus. This patient is in active disease. Which of the following drugs is the first line DMARD for rheumatoid arthritis? For rheumatoid arthritis, the first line DMARD is methotrexate. Okay, hydroxychloroquine, this drug is for SLE. Okay, but methotrexate is for rheumatoid arthritis, DMARD for rheumatoid arthritis. Which of the following is associated with HLA-B27? Your options are rheumatoid arthritis, ankylosing spondylitis, gout, and osteoarthritis. HLA-B27, you have to mark ankylosing spondylitis. 90% of patients with ankylosing spondylitis have HLA-B27 positive. But that doesn't mean that if you have this HLA-B27 type, you will certainly develop. No, that is not what it means. But 90% of cases of AS can have positive HLA-B27 association. A patient with rheumatoid arthritis is positive for rheumatoid factor. Which class of immunoglobulin is it? So your options are IgG, IgA, IgM, and IgE. Now don't get confused here. The rheumatoid arthritis rheumatoid factor is an IgM type isotype of antibody which is against IgG. Okay, so you have to mark that the rheumatoid factor is IgM type of antibody. And a 17-year-old female presents with swollen first metatarsophalangeal joint. The synovial joint shows negatively birefringent needle shaped crystals. Which of the following is the diagnosis? Now you have a 17-year-old female and then single joint involvement, and the fluid, synovial fluid, is showing this typical negatively birefringent needle shaped crystals. This is all fitting into what? This is all fitting into gout. Okay, so this negatively birefringent needle shaped crystals are due to MSU, which is monosodium urate crystals, right? MSU, monosodium urate crystals, and they are diagnostic of gout. So here your answer is gout. I hope these 20 questions have been useful for you all. Drop your comments in the comment section below and let me know what should be our next topic of discussion. Happy studying.